All right.
Hi, Mark. How are you?
Hello, good. Thank you, Dr. Verma, for the great introduction. And yes, endophthalmitis, devastating disease, and I'll be talking a little bit about how it relates to a screening paradigm that many of us are quite familiar with. And so, thank you again for having me from here in Baltimore, in the United States. Here, I have no financial relationships. So I'll be starting off talking about the screening paradigm, where basically from the Infectious Diseases Society of America, there is obviously a lot of worry, and understandably so, for this devastating disease and infection throughout the eye. And for Canada, blood cultures that are positive, there's basically this guideline coming from that society saying that every case needs an eye screening exam. And it's puzzling to many ophthalmologists because while it is devastating, you want to prevent this and treat it right away. It's actually rarely found on exam in many people's anecdotal experience. When we look back as to why this may have occurred, notice that in the early literature, even 40 years ago, there was as high as 37% rates of people with positive fungal blood cultures, or fungemia, candidemia. And you can see one of these black and white photos clearly showing a whitish lesion coming into three-dimensionally in front of the retina, which would be consistent with endophthalmitis. So obviously, this is something that we would want to stop and prevent. However, we move forward 10 years later in a prospective multi-center study trying to look at this question, published in the same journal. And this was down in 3 different centers: Duke, Wake Forest, and University of Pittsburgh. Over 2.5 years, actually looked at this question and adhered to very stringent criteria for endophthalmitis, coming out of the National Eye Institute with Newson-Black criteria. And what they found was not a single case fulfilled criteria for Candida endophthalmitis, meaning there was no frank vitreous involvement. Notably, we look at the other criteria, and as you can see, it's quite vague. There's probable or possible chorioretinitis. There are non-specific findings. There are other retinal findings that are often coexisting with these very sick patients. And I think at the same time, it's one of those where we have to be cognizant of these comorbidities. So moving on, about 20 years later, we notice that there's still now all this question happening. Should we even be doing these screenings? Why are we not finding them on blood screening exams? And so why is this decrease? Are we just finding the candidemia faster? Is there just better systemic antifungal treatments? Is it getting to the eye better? And should we even continue screening? And so what we sought to do is determine the actual true rate of sight-threatening disease in this setting and determine the outcomes of indiscriminate screening for candidemia. And when we looked at all possible studies within the literature, we found 38 of them that were able to delineate this question. Comes to about 7,500 patients, over 1,000 of which were actually prospective. The rest were retrospective. And we go back to this study because it shows a classic example here of what we found. And you can notice that in this black and white photo, we have a whitish lesion behind retinal vessels. So at most, this is chorioretinitis, but it might actually just be a nonspecific finding or even cotton wool spot, which does not have an infectious etiology. And you can see by their description that it was considered endophthalmitis if typical white fluffy retinal lesions were present, but nothing about the vitreous. As we can see here, this is a classic H&E slide from Dick Green's eye pathology lab here in Baltimore a number of years ago. And you can see budding yeast and polymorphonuclear leukocytes or neutrophils infiltrating from the choroid into the retina and into the vitreous. This is classic endophthalmitis. So what we required was endophthalmitis to have frank vitreous involvement. And among these studies, and their endophthalmitis reports, is concordant or discordant as to whether they followed these criteria. And what we found is quite striking. So before 1994, the rates of reported endophthalmitis were actually significantly higher than those after 1994. Again, we picked 1994 because of that prospective multi-center study that actually was the first to establish those criteria. And then similarly, those that adhered to the definition were significantly lower than those studies that did not adhere to the definition. And so the true endophthalmitis rate was actually less than 1%. And what was also striking is that even the cases that were consistent with endophthalmitis with positive vitreous involvement, none of them actually had fungal organisms within the vitreous, either by microbiology or histopathologic evaluation. So, okay, maybe not endophthalmitis, but what about chorioretinitis? And what happens in these cases of true endophthalmitis? Does an invasive ophthalmologic intervention with tap and inject or vitrectomy change the outcomes? And so we look at this flow chart, and being mindful here that these included outcomes data when they were available, because many times they were not, and also the fact that they were treated systemically per IDSA guidelines, which is critical because really when you have a Candida bloodstream infection, we want to treat the underlying cause, the bloodstream infection and source control. So minimum 2 weeks systemic antifungals, as well as exchange or removal of any indwelling catheters. So to be included in this, they had to follow those parts of the guidelines. Now, going to the left, you see the 78 patients with chorioretinitis with outcomes data, 3 of which were threatening the macula, which is obviously important when we're considering the importance of real estate within the retina. Obviously, the macula is the most important. And we noticed that none of them were treatment failures. So treatment failure was defined as vision loss or other aspects or loss of the eye or anything, deterioration of that vision. Meanwhile, the rest actually succeeded if they didn't die and weren't lost to follow-up. Notice how there's a lot of deaths. That's because candidemia is associated with incredibly high mortality. These are some of the sickest patients in the hospital, and they often have other comorbidities along with their Candida bloodstream infection. Now, we go along to the right side of the screen. We have 19 patients with Candida endophthalmitis. Again, none had confirmed evidence of Candida within the eye. One of them actually improved. This is from the late 70s. One of them actually improved with just removing the central venous catheter alone. No systemic antifungals were given. No eye treatments were given. Of the other 18, immediate systemic antifungal treatment, minimum 2 weeks. 12 just continued that alone. 6 died from the horrible disease that they have. 6 succeeded where there was resolution or improvement of vision, and none actually failed. Meanwhile, 6 others had additional invasive intervention with either tap and inject or vitrectomy or both. It actually ended up being 2 of each of those 3 different permutations. Half of them improved, half of them did not. And so there was association between success and medical management alone versus those had invasive management and treatment failure. However, it's very limited to be able to do this. The sample size is incredibly low. Vitreoretinal disease extent was not measured. It was not randomized. So there's limited amount of stock we can put into this, but at the very least, it tells us that there's at least no data showing that there was actually a benefit for these patients. And so out of these 7,500 patients, we have data here showing that as few as 3 of them may have benefited. And the mortality rate was also quite high, consistent with literature. About 25 to 30% of these patients ultimately die within 6 weeks of their disease. And there was actually no treatment failures with prompt systemic management for either endophthalmitis or chorioretinitis when it was found. And so Atobascum polymer is actually one of the largest culture positive studies to date, showing that, in patients with proven fungal endophthalmitis from specimens inside the eye, only 12% actually had a positive blood culture. So we're basically just missing the target here. We're trying to find this rare disease and a devastating one by screening blood cultures, but it doesn't really seem to be lining up with what we find clinically. And these patients often have devastating outcomes. I mean, up to 30% have retinal detachment, which, as we know, is quite poor in the setting of endophthalmitis. What about systemic therapy? Wouldn't that change management? Well, the Spanish actually looked into this. Several of their centers together through the CandyPop Coalition, they actually determined that echinocandins, because of the concern of not being able to get into the eye, there was actually no difference in retinal findings between those with echinocandins for the Candida bloodstream infection versus those treated with amphotericin B and azoles, those that are more classic antifungal treatments. And this makes sense because the inner choroid is actually the focus of where these lesions typically present. And so it's, as we know, one of the most vascular tissues of the body. It shouldn't matter whether it gets into the vitreous or not for getting the origin of these lesions when they hit the eye. And so being outside the blood retinal barrier, it would make sense that it would get adequate treatment in those areas. And we see this on OCT as well. Clinically, we have a similar focus right outside the retina where many of these classic lesions present before penetrating into the retina. And so going back to these nonspecific lesions and chorioretinitis versus probable and possible, this is actually one of the best papers out there that illustrates how we would normally find abnormal retinal findings in patients that are sick in the hospital, regardless of candidemia. 19% of them have abnormal retinal findings. And this is actually a similar statistic to what the IDSA demonstrates in their guidelines that provide the basis for these screenings. So just because a patient has abnormal retinal findings in the setting of candidemia does not mean that that patient has those findings because of candidemia. Often they have anemia, they have hypertension, they have HIV, they have other kinds of problems, other medical comorbidities to explain those findings. So the bottom line is we don't want to be intervening on findings that aren't necessarily related to infection in the first place. And so our Canadian neighbors have illustrated this quite well with their studies, up to 17 years for de-adopting low-value clinical guidelines and practices. We don't want to be overusing and misusing resources that are both wasteful and potentially harmful. The British have gotten together, they're ophthalmologists and intensivists together, and they actually decided that we should be doing this on an exceptional case-by-case basis. And then we followed them shortly thereafter. I hate to say it, as the Americans, we followed the British, but we finally came out in the last couple of months that we recommend, the American Academy of Ophthalmology does not actually recommend this routine screening guideline practice no longer. And so in summary, endophthalmitis continues to be, thankfully, exceedingly rare. And even in this case, the folks should be treated on the underlying cause, candidemia with prompt systemic antifungals and catheter exchange. We do not want to be delaying this treatment, as Dr. Verma was saying, with any kind of endophthalmitis, and current evidence suggests against indiscriminate screening. We really need to be doing the whole entire clinical picture. Take questions, and thank you all for your time.